Hi everyone, my name is Julia Amundson. I'm a PGY3 research resident at the University of Chicago working with the North Shore Group. First of all, I'd like to just thank SAGES and the moderators for the opportunity to present our work. I have nothing to disclose. Here are the disclosures for our other authors. So we all know that POEM is an excellent option that has benefits over Heller myotomy with the significant drawback of high rates of postoperative GERD. To date, there's been no widely adopted technology or technique that provides feedback in the operating room on adequacy of myotomy to both improve Eckardt score and minimize GERD. Impedance planimetry, also known as FLIP, is a technology that tells us about the geometry of sphincters within the gastrointestinal tract. When we're doing POEM, we place it across the lower esophageal sphincter, and you see an hourglass on the monitor as demonstrated in the right side image here. One of the metrics that's frequently reported on generated by the FLIP system is distensibility index. This is a measure of how tight or loose a sphincter is, and it's generated by dividing the cross-sectional area of the narrowest plane of the sphincter by the intrabag pressure measured by the balloon. Of note, this is just measuring a single plane where the sphincter is narrowest. Compliance, in turn, measures a volumetric change in response to a change in pressure. So it's calculated along a 2-centimeter segment centered around that narrowest cross-sectional plane, the same one used in the distensibility index calculation. And we believe that this may be more representative of the function of the lower esophageal sphincter than distensibility index, which is just looking at a single cross-sectional plane. Therefore, the aims of our study were twofold. First, to just describe the relationship between post-POEM compliance of the lower esophageal sphincter and GERD and Eckardt score at follow-up, and also to compare the utility of these different metrics that are generated by the FLIP system, including distensibility index, cross-sectional area, and compliance, and how they correlate with postoperative Eckardt scores and GERD. So this is a retrospective review of a prospectively maintained quality database of all patients undergoing gastroesophageal procedures. And we chose to include patients who underwent POEM and intraoperative FLIP that had compliance values available for analysis. The study period was from January of 2019 through November of 2021. For our FLIP protocol, we used an 8-centimeter EF325 catheter for all the patients. And for the first half of the study period, we did exclusively a 30 milliliter fill, and for the second half, it was both a 30 and a 40 milliliter fill. For patients that did not have a compliance generated by the FLIP system, we underwent a post hoc review of archived intraoperative FLIP data to calculate FLIP, the compliance. This is replicating a previously published methodology that was created in conjunction with industry professionals, and we did go back and double check a subset of those patients who had FLIP, compliance generated by the FLIP machine with the calculation and found 100% concordance. So, during the study period, we had 35 patients who underwent POEM and also had compliance available for analysis. They were patients who had type 1, 2, 3 achalasia and esophagogastric junction outflow obstruction. We excluded patients with diffuse esophageal spasm or jackhammer esophagus due to normal LES. We defined clinical success as an Eckardt score less than 3. And our Eckardt scores improved in our cohort from a mean of 5.5 at pre-op to 1.3 and 1.8 at first and second post-op visits, respectively. Overall, in our cohort, we had a significant increase in compliance from pre to post myotomy on the intraoperative measurements at both a 30 milliliter and a 40 milliliter fill. At a 30 milliliter fill, it increased a little bit more, about 80%, and at a 40 milliliter fill, it increased by 77%. Looking at all the other metrics generated by the FLIP system, we saw a parallel in how the compliance changed, increasing from pre to post myotomy in the minimum diameter, the cross-sectional area, and the distensibility index. All of those changes were significant, and there was a corresponding decrease in the intrabag pressure at both a 30 milliliter and a 40 milliliter fill. When we stratified our patients by symptomatic resolution, again defined as Eckardt score less than 3 at follow-up, we found there was a significant association between a lower Eckardt score at first follow-up and a higher compliance for patients at a 40 milliliter fill. And although that trend persisted at second follow-up, it was no longer statistically significant, which we think may be due to about a 50% dropout of patients not completing a second follow-up. Based on that data, we were able to define a cutoff value of compliance greater than or equal to 125 millimeters cubed per millimeter of mercury, again using the 40 milliliter fill, as being associated with a lower Eckardt score at both first and second postoperative visits in our cohort. This is a scatter plot just showing the small subset of patients that had follow-up for GERD. There were 11 patients who completed either upper endoscopy Bravo or reflux symptom index questionnaire. The patients who did develop GERD, defined as either grade C or D esophagitis on AGD, a positive Bravo study, or a reflux symptom index questionnaire score greater than 13, are shown here in blue, and their compliance is what's shown on the y-axis there. Those who did not develop GERD are shown in orange. As you can see, there is significant overlap between the compliance at the post-myotomy time point between those who did and did not go on to develop GERD. Therefore, we were unable to define an upper limit of compliance that would limit the development of de novo postoperative GERD, and it led us to believe that compliance may not be a good predictor of the development of postoperative GERD. So we've defined this new cutoff value, and we're looking at a metric that's not widely reported on in the FLIP literature. What we wanted to do to see is this a better predictor of postoperative Eckardt score than previously defined ideal ranges? So we compared our cohort to previously defined ideal cross-sectional area, which is 80 to 95 millimeters squared using a 30 milliliter fill. And we found that only about 8.5% of our patients fell into that ideal range. And it was not significantly associated with Eckardt score at first follow-up, and none of those it was only 3 patients, none of them completed a second follow-up. When looking at a previously defined ideal range for distensibility index of 4.5 to 8.5 at a 40 milliliter fill, we again did not see a significant association between Eckardt score at first and second follow-up and falling within that ideal range. Whereas with our cutoff that we defined for compliance of greater than or equal to 125, we did see a significant association at both first and second follow-up. And you can note there that the Eckardt score in that cohort is less than 1, so resolution of achalasia symptoms. There are noted limitations to this study. It's retrospective analysis, in spite of the data being prospectively collected. It is a very small sample size. We were limited in several ways. We didn't realize until after the study period had concluded that unless the sphincter of interest is very well centered on the monitor, a compliance metric is not generated by the FLIP system. And early in our institution's impedance planimetry experience, we did not archive all the intraoperative FLIP data, so it wasn't available for post-hoc review. Secondly, we changed our FLIP protocol during the study period. Initially, we were just collecting data at a 30 milliliter fill, but we noted that there are a lot of patients that had an intrabag pressure less than 20, which means that it's not a super reliable output that you're getting, and that the bag may not be very well opposed to the walls of the esophagus. And so we then changed our protocol to being both 30 and 40 milliliter fill. And the majority of patients who did complete a second follow-up did so at less than 3 months. So we do expect to see some both loss of treatment effect and further development of de novo GERD with longer-term follow-up. So in compliance, in conclusion, we found that a compliance of greater than or equal to 125 was associated with a normalized Eckardt score both first and second follow-up, and that it performed better than previously defined ranges of cross-sectional area and distensibility index in predicting postoperative Eckardt score. We do need further study to see if it's of any use in predicting those who will develop de novo GERD after POEM. Thank you. Happy to take any questions.